Thank you. Welcome everyone to this talk. My name is Gunilla Sandborgh Englund, and I will present to you what I'm up to these days. Since the last 2 years, I've been the director of the Academic Center for Geriatric Research. And when I got this task, I have changed the focus of my research. I will tell you a bit about the Academic Center for Geriatric Dentistry. This is a regional academic center founded in 2013. It is a collaboration between the Department of Dental Medicine at Karolinska Institutet, the Public Dental Service, Folktandvården in Stockholm, the Foundation of Stockholms sjukhem, and also the Stockholm County Council. And it is situated at Stockholms sjukhem here in Kungsholmen, inside the dental clinic, in fact. So the mission of this center is to improve oral health in older persons through research, through education, and clinical practice. And an important task is also to disseminate the knowledge to others. And the ambition of the center is to be acknowledged as a national center. Yep. So the center organizes research, education, and information. The education is not so much undergrad teaching as it is teaching towards other professionals, such as nursing professionals, medical staff, etc. We do have dental students coming to ACT for practice and also for master work, master thesis. The dental care in the clinic is the public dental health service is in charge of the dental clinic and the service they provide. And it's a specialized clinic which gives comprehensive dental care to individuals with special needs, such as elderly. Okay, so I'm the director of the center, and as a co-worker I have a co-director, Pia Scott. She's a PhD, and she's also the head of the clinic. And we have arranged the work with research in the center in core groups, which means that we have made specific groups around research areas where we involve senior researchers from adjacent research areas into the groups. Okay, so why is there a need for more interest and more research in geriatric dentistry? I picked some stats from different places. The first thing is that we live longer these days. And we see a rapid increase here in the number of people aged 80 and above. So this prognosis gives us a hint about 100% increase until 2035. Okay, so the number will increase. Another aspect is that we keep our teeth. This is from the Dental Health Register, showing that we keep our teeth up into old age. As you can see here, a 90-year-old has on average 20 teeth in the mouth, which is, we consider, almost a full dentition. Not so long time ago, when you went to a nursing home, for instance, you could see that most of the patients there, they kept their teeth in a glass of water beside the bed. This is not the case any longer. Instead, they have complicated reconstructions such as implants, crowns, bridges, etc. Okay, so there's a huge need to take care of these teeth in this period of life. Other statistics I picked up was how often do we go to the dentist? I think this is interesting. In fact, the group that goes most often to the dentist is the ones between 70 and 79. But thereafter, we see a quite rapid decline in the visit rate. So this shows if they go every year, every second year, or every third year. But on the whole, we can see a quite steep decline thereafter. And this has been shown in other ways, that there is a risk of losing contact with dental care when you get older. This is a study from 2016 showing that the older you get, the larger proportion of the population loses contact with dental care. So up to almost 30% in the end here. And on the other hand of this, we know that the risk for disease, in particular caries disease, increases. And what is known, if you're care dependent, the risk increases even more. So here's a study, a report from Västra Götaland showing that in the oldest age group and in care dependent individuals, the risk is really high. The risk is 50%. And otherwise, we consider caries as a disease in children, but it is also a very common disease in old people. Okay, so once you get into these old ages, you often you're in need of help with lots of daily activities. And the persons who will help you is most often nursing or nursing staff, care aides. This is a report from Uppsala, where they did an intervention by teaching nursing staff about oral hygiene and how to perform oral hygiene. And they asked the staff before and after this education, what are the tasks that you consider most difficult to perform? They asked about hair wash, diaper changed, oral hygiene, and feeding. What I think is a bit depressing and worth to really take in here is that they consider oral hygiene as a very difficult task to perform, both before and after teaching. They really did not see any improvement. So we have a huge task here to teach nursing staff about oral hygiene and to change their attitude and their skills to do this. Yep. What happens when you get old? Well, of course, you can be old and be healthy. And you can keep your dental contact and you can keep up the standard of your hygiene and you can look like this when you're 90. That's no problem. But the problem is the ones that lose contact due to, for instance, they get ill, their partners are ill, or they don't have the power to keep up, and they lose interest. There are other things more important to them in life. They lose contact and they also lose the standard of performing the hygiene. They only go to the dentist for emergency visits. And when we pick them up, maybe when they enter they come into a nursing home, for instance, we can see disasters, really disasters. And then it's really much too late to do something really worthwhile. I mean, it's really difficult to do something good here. So what we think is important is to focus on the frail period, the period when old people are beginning to get a deteriorated health in all, and to keep them as our patients, not lose them, in order to keep up quality of life and oral health. Okay, so we have several challenges working with geriatric dentistry. I mentioned some of them. They lose contact with dental care, many of them. We need more education of dental professionals to work with old, frail people, because you need to adapt your treatment goals, etc., when you work with these age groups. We need to educate nursing staff And we need, of course, to change both attitudes and skills. So there is a need for a multidisciplinary cooperation. In addition to this, we have a really complicated remuneration system in Sweden. I will show you a slide on that. And last but not least, integrity and ethics. When patients lose cognitive skills, they maybe don't want to cooperate, but then this stands against when you see an obvious treatment need, what to do really. You can be put in a treatment dilemma really. Just to show you that we have several support systems for old people, marked in green here. Many of them require medical certificates so the person gets the right to be entitled to this support. But the poor knowledge of this system makes it really hard. Many medical doctors are not at all informed about what is needed, what is there, what right the patients have. So I would like to see a simplified system really here. And of course better knowledge on the medical side. Okay, so I will tell you a bit more about the research now. This is the background. The research really targets the complex interrelation between oral and general health and the quality of life. As an example, we have that compromised eating and swallowing abilities will of course affect nutrition. And nutrition in turn will both will contribute to an impaired quality of life and will contribute to cognitive impairment and also to frailty. And then the systemic disease can also heighten the risk for oral disease and vice versa. And in the old age groups, we also often have patients suffering from multimorbidity and polypharmacy, and this may further generate oral and general complications. I'll just give you a short list of the projects, the ongoing projects at the center, then I will present the two ones more in detail. So we look at the dental care utilization in Swedish patients. What does it look like, in particular in conjunction to dementia? We're studying polypharmacy. What impact does that have on oral health? We're performing an oral screen training, RCT, in stroke patients. You know, stroke patients many times suffer from swallowing problems after stroke. And we're interested in investigating if training with oral screens can improve their swallowing function. And I don't know if you're aware of that there is a link between cognition and mastication, cognition and chewing. There are lots of studies, and very recently there was a systematic review showing that there is an association between mastication and cognitive status. So we're planning an intervention study where we'll rehabilitate the mastication in older people and check if there are any cognitive changes related to this. Can we improve cognition by restoring mastication? That's the goal. And in conjunction to this, we also have a PhD project focusing on objective and subjective measures on chewing and mastication. What are the important aspects here? An additional project works with strategies to identify individuals at risk for frailty. You know, as I showed you previously, the persons that go most often to the dentist are in the age group of 70 to 79, so they see the dentist very regularly, more regular than the doctor probably. So could dentistry be in help here to identify frail persons at risk for frailty? for instance, for osteoporosis, just by using dental x-rays. And then the last one is focused on domiciliary dental oral care, professional oral care. There's many people working with domiciliary dental care, but is it of help? Does it really improve oral and general health in older people? So in this center we have 4 PhD students, we have 4 postdocs, and around 10 master students working with their assignments. Okay, I will now present a bit more about the second one, the effect of polypharmacy on oral health. It is quite well known, familiar to all of you, I guess, that many drugs cause dry mouth. So this is, I got this from National Board of Health and Welfare, where they have recently published a report showing that if we look at individuals aged 65 or higher, around 25% are prescribed one drug, up to 35%, 2 to 3 drugs, and around 15% more than 4 drugs or more causing dry mouth, which is quite a lot. So if we sum this up, we can conclude that 76% of the population aged 65 or higher, they take one drug or more causing dry mouth. And in the older part, 85 or higher, the corresponding number is 86%. I mean, this is a large majority, I would say. The drugs we're talking about, we have sort of clinical experience and also, of course, research data that antidepressants, antipsychotics, anticholinergics, antihypertensives, and antihistamines are medications that cause dry mouth. And the side effects, if you're dental students, you know the side effects, but for the rest of you, having a dry mouth will affect your swallowing and your eating. It will affect the oral clearance of debris. If you look into a dry mouth, it can really be messy. It increases the risk for caries dramatically. And it can also affect periodontitis, periodontal infection, and other infections. And, not least, it affects the quality of life of the patients. Okay, so what about the evidence for this? I mean, this is something that we take sort of for granted, but what is the evidence? So what we'd start by doing is a systematic review. So we wanted to do a systematic review focusing on the older population. So we did a literature search, as you do in a systematic review, where we focused on older people aged 60 and above. And we choose intervention or observational studies on drug use as an exposure and serostomia or salivary gland hyperfunction as an outcome. And we found 1544 potentially relevant studies and 52 that we could include in our final review. Of these, we had 26 for inclusion in a meta-analysis. So the results continues here. We conclude that the majority of studies were of moderate methodological quality. The main part were experimental studies, like drug studies. And we found lots of studies, 16 in urinary frequency and incontinence drugs, and then 10 in antidepressants, 3 antipsychotics, and then 1 of each of cardiovascular, hypnotics, sedatives, epileptics. And then we also found a few cross-sectional studies. In these studies, the drug exposure ranged from 2 weeks up to 1 year. The experimental studies are often shorter, and a backside of the experimental studies is that they don't use dry mouth as an outcome. It's reported as an adverse effect. So what we get is information about yes, no, if the patient says yes, I have a dry mouth, or no, I have a dry mouth, which is not, so it's their subjective view, not objectively measured. In the cross-sectional studies, they have often measured saliva flow. But not least, we did this meta-analysis and showing that for the urological drugs, we have, maybe difficulties here, but we have an odds ratio of 5.91 for them causing dry mouth, which is really high. Compared to antidepressants, 474, a bit lower, but still very high. And psycholeptics, which were not so many studies, 259. So we conclude that we have shown here that these three groups of drugs were significantly associated with dry mouth. And from the observational studies, it was not a strong evidence, but they showed that there were, for one part, the number of medications that the patients use, and then several medication classes that were associated with either xeristomia or with salivary gland hyperfunction. What we would like to do in the future is to develop a risk score, because we think this would be of great value for medical doctors and prescribers, to sort of a tool for them to tell the risk, and if there is a risk, they could refer to dentistry. So this is something we'll continue working on. The next step will be that we're performing a register-based study where we link the dental health register to the prescription register and see if we can find any evidence for an association between medications and oral health. All right. I will describe a second paper that we have been working with and is published. It's where we studied the dental care utilizations in patients with dementia. This is a longitudinal and nationwide study. We had 58,000 patients in the study. So we used data from the Swedish Dementia Registry and the Swedish Dental Health Register, and for the period of 2007 to 2015. From the total population, we had to select those that had been to the dentists. So it came down to 42,000 almost. We can see here that they had the mean age at diagnosis of 79 years. They had an MMSE score. MMSE, Mini Mental State Examination. It's a tool used to measure cognitive function. And the maximum is 30. And it's stated that if you have a score below 24, you have a dementia. Almost half of the population were living alone, and a third of them had home care. And we also saw that they have lots of medication. The biggest group is cardiovascular drugs, and then they had the cholinesterase inhibitors, antidepressants, and so on. And on average, they have had 5.4 drugs prescribed. Okay, so what we show in this paper is that there is a decrease in the use of dental care. And if we divide the population according to their MMSE score, we could see that the ones with the highest score, the closest to normal, they have the highest utilization, and then it declined. So the lowest group, the group with the lowest MSE score, they went more seldom to the dentist. In all groups here, we saw a decline in the use of dental care. Not rocket science, but still very valuable information. Another thing we could show was that if they had a more rapid decline in their cognition, the change in their MMSE score, we could see that they also lost contact with dentistry more quick. So the fourth quartile here is the one with the steepest reduction in MMSE scores over time. And they also had a lower number of visits to dental care, or a greater reduction. So we concluded here that the rate of dental care visits declined very significantly after the dementia diagnosis. Also that those with a more severe and faster impairment had a higher rate of decline in dental care utilization. And the ones with low MMSE baseline score, this was a significant predictor for loss of teeth. So to give some advice, what we would like to see, we need to facilitate adequate dental care for this population. And we need to lift the risk of oral health being neglected in various dementia care guidelines and workups. We will continue working with this type of studies in the future, and I think we will. What we're planning to do is to have another base of patients, not only dementia patients, but all patients as a whole, and see about the dental care utilization patterns. I think I was a bit quick here because this is my last slide. I just like to present our various research collaborations, which is mainly within KI, where we work with the department researchers at MBS and also at clinical epidemiology at KI in the Department of Medicine. We work with the research unit at Stockholms sjukhem. And we have collaboration also with the academic primary health care centers in Stockholm. And we have quite a large cooperation and cooperation with other regional geriatric dentistry centers. And if you want further details, I can direct you to our website at adretandvård.se. And now I'm happy to take your questions.